Cardiac autonomic neuropathy is a serious but often underdiagnosed complication of diabetes and occasionally other metabolic disorders where the autonomic nerve system, which controls involuntary heart and blood vessel functions, becomes damaged. It essentially disrupts the autopilot of the cardiovascular system, leading to issues with heart rate control and blood pressure regulation. Symptoms can range from subtle to life-threatening. Key indicators include resting tachycardia, a consistently high heart rate even during sleep or rest caused by a loss of vagal parasympathetic tone. Orthostatic hypotension, a significant drop in blood pressure when standing up, leading to dizziness, lightheadedness, or syncope. Exercise intolerance. The heart fails to increase its rate appropriately in response to physical exertion, that is chronotropic incompetence. Silent myocardial ischemia. This is perhaps the most dangerous aspect. The nerves that transmit chest pain are damaged, meaning a patient might have a myocardial infarction without experiencing anginal pain. Perioperative instability. Increased risk of severe blood pressure swings or arrhythmias during general anesthesia. Established risk factors for autonomic neuropathy are glycemic control in type 1 diabetes mellitus, hypertension, dyslipidemia, obesity, and glycemic control in type 2 diabetes. Diagnosis of cardiac autonomic neuropathy typically involves cardiac autonomic reflex tests, which are considered the gold standard. In Valsalva maneuver, patient exhales against resistance. Abnormal response is lack of expected heart rate slowing and speeding in the typical Valsalva response. Heart rate variability. Measuring RR intervals during deep breathing. Reduced variation, flattened rhythm can be noted. That is short-term heart rate variability. Orthostatic challenge. Moving from lying to standing. A drop in systolic blood pressure more than 20 millimeters of mercury or diastolic drop more than 10 millimeters of mercury are abnormal responses. Deep breathing ratio, EI ratio, assessment of vagal parasympathetic tone, often the first to become abnormal. Valsalva maneuver, Valsalva ratio, longest RR at rebound and shortest RR at peak strain are compared. This tests both sympathetic and parasympathetic reflex arcs. 30-15 ratio, peak heart rate at 15th beat and least at 30th beat. Postural RR change, longest RR at beat 30 divided by shortest RR at beat 15. This measures the immediate heart rate response to standing. One abnormal cardiovagal test result identifies possible or early cardiac autonomic neuropathy. At least 2 abnormal cardiovagal test results are required for definite or confirmed cardiac autonomic neuropathy diagnosis. The presence of orthostatic hypotension in addition to abnormal heart rate test results identifies severe or advanced cardiac autonomic neuropathy. While the neural damage itself is difficult to reverse, management focuses on symptom control and risk reduction. Intensive blood sugar management is the only proven way to slow the progression of cardiac autonomic neuropathy, especially in type 1 diabetes mellitus. For orthostatic hypotension, patients are often advised to increase salt and water intake, wear compression stockings, and move slowly when rising. Midodrine or fludrocortisone can be used for severe orthostatic hypotension. Cautious use of beta blockers may be useful for resting tachycardia. ACE inhibitors can provide cardioprotection in diabetic patients. Annual screening for cardiac autonomic neuropathy is recommended for type 2 diabetes at diagnosis and for type 1 diabetics 5 years after diagnosis. Because cardiac autonomic neuropathy is a strong predictor of cardiovascular mortality, patients with confirmed neuropathy require aggressive management of all other risk factors, including dyslipidemia and hypertension.